Hi, I'm Patrick Hagan. Welcome to From Nothing, where my co-host Ian Sefferman and I go deep with healthcare founders on how they actually got started. Today we talk with Dr. Amy Mezulis, co-founder and chief clinical officer at Joon, an evidence-based teletherapy service for teens and young adults. We discuss how she and her co-founder Josh Herst met and got started, the dynamics that drove mental health to the forefront during COVID for teens and young adults, how they scoped their product at launch and got their first patients, balancing business and clinical needs, and more. We hope you learn as much as we did from our conversation. Amy, thank you for joining us. We'd love to just get started with, quick intro on what is Joon and your role there.
Sure. So Joon is a teletherapy company dedicated to bringing evidence-based mental health care to teens and young adults by leveraging technology to combine kind of live face-to-face therapy with therapists with digital solutions to enhance both therapists' ability to deliver evidence-based care and clients' ability to engage and access it.
Very cool. And you're chief clinical officer, correct?
I am chief clinical officer and co-founder. Yep.
And how do you, what's kind of like the split of duties between you and your co-founder, Josh, as CEO?
Sure. So Josh Herst is my co-founder and CEO. We actually have a pretty formal org chart that separates out clinical duties from sort of business and product duties. And that's in part because you're sort of setting up the stage for some regulatory issues. So most states require that all healthcare be delivered by a professional core that is sort of run and managed by clinicians as opposed to run and managed by business folks to ensure that the quality of healthcare is adherent to clinical standards. So as chief clinical officer, I run basically all clinical services. So scope of care, training, hiring, training, and oversight of therapists, and sort of, supervising the delivery of all clinical services. What's our scope of care? What's our model of care, and ensuring that that is delivered to clients effectively.
When did your story intersect with Joon and with Josh and with?
Sure. So Josh's journey started before mine. So maybe I'll tell you a little bit about how he kind of came to thinking about what became Joon and then where I sort of stepped in. So, so Josh previously had founded WalkScore, a real estate company, tech company that he sold to Redfin. And in the intervening years, as he was sort of thinking about coming back into the entrepreneur space, became sort of interested in the question of mental health. I'm a parent of two teenagers. He is also the parent of two teenagers. If you're paying attention, there's been a pretty significant mental health crisis among teens and young adults. And so I think just seeing notices from his kids' schools, he was sort of just volunteering with a social services agency here in Seattle. And I think was just kind of aware of the mental health problem, became interested in is that a space where he could sort of reapply some of his passions around, using technology in an entrepreneurial way to solve social problems, which is kind of the heart of what Josh likes to do. So he started thinking about the idea of doing something in the adolescent, young adult mental health space. Before he met me, he was an entrepreneur in residence at Pioneer Square Labs, kind of thinking, talking with lots of different people, including University of Washington, Seattle Children's. And at some point having one of those conversations with Greg Gottesman and said, hey, I'm really kind of interested in this adolescent mental health space and what we can do with technology to improve treatment. But I know nothing about adolescent mental health. I happen to know Greg really well personally also. And so Greg was like, hey, I know someone who knows something about adolescent mental health. And so we kind of met for the first time sort of early fall of 2019, and started kind of just talking through some of those ideas. What do I know about kind of what the main problems are in the adolescent mental health space, and what do we know about treatments and interventions, and where might there be places from Josh's side where technology could start solving some of those problems, knowing that access to care, engaging this population, some of the unique clinical characteristics of this population really matter. So those are sort of like content side that I know. And mental health, it sounds like you guys have probably spent a lot of time in the mental health and wellness space, but we've been pretty slow to embrace technology. Like we're pretty old school. You're considered pretty technologically savvy if you can turn a worksheet into a PDF and email it to your client. So, he had lots of ideas about how technology could make these pieces better everywhere from connecting therapists with clients to the sort of delivery of care. So we started talking in the fall of 2019, kind of came up with the idea of sort of the broad strokes of what has become Joon. Really kind of honestly, as we were ending 2019, probably thought we'd spend most of 2020 continuing to think and develop, kind of work on a prototype of an app, work on the prototype of this therapist platform that we've developed, and launch maybe in summer or fall of 2020. And then COVID hits. And we really just sort of said, hey, like the need was already so high, but the need just skyrocketed really quickly. That was really apparent. And we just accelerated our entry into market at that point. And so really 2020 has been the story of how Joon itself came to be. We had a different name to start with, of course, as a lot of companies, a lot of startups do. And so
And
we
I'm
had
kind of
really
curious
just,
about that one. Sorry to interrupt.
okay.
What precipitated the shift from Uplift to Joon?
Oh, it's easy. Uplift was not a domain that we could have proprietarily. There were lots of companies using the name Uplift in some way, including not a well-known or well-branded, but including a mental health and wellness company. And so we loved the name. I mean, we really did. And it spoke so much to our mission, but we just knew it wasn't a good long-term brand solution. And so that's a whole fun story of how we came up with the name Joon. Happy to tell you that story at some point. But yeah, so we knew from the beginning that Uplift was not a permanent name. It just took us a while. We actually settled on the name Joon decently early, and then it just took a while to buy the domain. It was being held hostage by like some guy living on an island in the Caribbean. As domains are, we were able to get Joon Care and Joon Therapy, but we really wanted Joon.com. And so it just took a while to get that. But that was really, we knew going in that Uplift was going to have to be temporary, unfortunately. So
Yeah, we know that domain juggle game very, very well. You kind of hack it as you have to.
you do it as best you can.
So it sounds like you and Josh started speaking because you were obviously the expert. He's like, I need to get smart on this realm.
Yep.
At what point were you like, I think I want to do this?
So I sort of started kind of consulting, really. I mean, I've been on the faculty of a university here in Seattle for 15 years. And so I kind of had a gig. I mean, I was working, had a full-time gig plus, because I was also had just gone into private practice a day a week. And so, sort of talking, I think originally I kind of thought, no, this might just be more consulting on content and consulting on kind of scope of care. And then, I think the more just one of those synergies that starts to build over time, I think the more it became clear what it was we were going to build and how intricately related sort of content expertise and clinical background was going to be with the digital solutions that at some point in there, Josh has said to me, I think we're ready to do this. And do you want to come on as co-founder with me? And it didn't take me a whole lot of time. I just had to sort of stop and be like, do I have the time for all this? But the idea of it was just so really compelling to me. And, for me personally, and Josh has heard this story a million times, but, it came for me at a time in my professional life where I was kind of at a bit of a decision point about sort of how much academic and research focused I really wanted to be. I'd kind of closed out a pretty significant chapter of federally funded research and was kind of thinking kind of like, what's the next big sort of professional thing I want to do? I'd hit a lot of my professional goals in terms of research, publication, even administration. I was department chair and full professor. And so I was in my mind kind of looking for like, what's my next passion project? And where can I have impact? And I was looking for a way to have more impact clinically and in the daily lives of adolescents and young adults. So there was a lot of like sort of fortuitous timing, I think, between the two of us. If this had happened 3 years ago, I would have been in the middle of a federal grant. I would never have had the time to do it. Who knows, where we would have been a couple of years from now. But the timing worked really well too, if that makes sense. So
Yeah. And what's been the hardest thing for you coming in after a career in academia and research into early stage startups?
So first of all, I still have my academic gig. So I kind of split my time between my academic role, which has there's just a tremendous amount of synergy, and there's a lot of value to Joon for my maintaining my academic credentials and relationships, and vice versa. The whole idea of clinical psychology is that we're a scientist practitioner model, right? Where the science should be informing practice and practice should be informing science. So there's a lot of two-way exchange there that is valuable. Um, the hardest thing for me, and I had a small advantage in the fact that my husband had been the CEO of a tech startup at the time that he died in 2017. So I'd been kind of on that journey with him for a few years. But honestly, the hardest thing has just been language and speed of processing in the business world is just completely different than academia, right? Like academics like to sit there and spend 5 years doing 2 randomized controlled trials of 20 patients each, right, to test a little tiny piece of one idea. And then we want to test it again and confirm our results. And then we want to publish it. And then maybe we'll try it with 30 people. And so this idea of like, let's go to market with what we know and like, sort of disseminate it broadly is just a little counter to a sort of the very conservative pace of academia. And I think for Josh also, I think a lot of academics sort of sit out here in terms of like pace of disseminating science into practice, right? They are pretty conservative. They really want to test and retest and triple test and quadruple test, and are pretty wary about commercial applications of the things that they know from academia. And a lot of business folks are really like, yeah, like there's something about best practice, but like, where's the profit here? Like, right, where can I make a buck, and where's the business model? And I think for this kind of endeavor to work, and Josh and I have talked about this a lot, is both sides need to kind of meet in the middle, right? Like I wouldn't work with just anybody. Part of why I can work with Josh is because I really trust that his heart is in the right place, that he really, truly at his core wants to improve the lives of adolescents and young adults, wants to help solve the problem of adolescent mental health. So he shares the same sort of clinical passion. And I think I probably just by my nature, but maybe also having kind of been sort of ancillarily in the sort of tech world just because of my personal connections, I probably am more willing than a typical academic to kind of step into that business space and say, hey, where can we leverage what we know, but make it more commercially available? So we found a place to meet in the middle, but I think that's a place where a lot of mental health ideas, potentials for mental health startups stop, is because it's hard to find that space where the two sides find a common ground.
Yes, definitely. Hence this entire podcast of like, we want to be able to meet clinically minded people exactly where they are,
yeah.
and kind of pull them a little bit in our direction, but also be very respectful and also mindful of, we have a real mission here.
We have a real mission. And we get asked all the time, what do you do about the issue of sort of moral hazard? What do we do if, Josh or / the business side is sort of pushing Amy / the clinical side to do something that I don't think is in client's best interest, because that's where the profit margin would be. And I mean, not that it won't come up, and not that we haven't had some places where he's like, why don't we do this? But when I say, well, the reason we don't do that is because of this clinical reason, like this is why it's not in clients, this is why it's not adherent to our model of care, this is why it's not in the clinical best interest of our clients, I've never once had any pushback from Josh around that. Like his, so I think the willingness to think about, how do we adhere to what we know the science supports, but still consider the ways in which those can be profitable, that there is a lot of space there. It just takes some willingness to find it.
Yeah. So kind of going back to the moment in time where you were consulting with Josh, and sounds like you both came to the decision of like, let's go do this. Where was the business in terms of its progress? Like, what did you know, and what did you definitely not know?
What did we have? We had an idea. I think the core of the idea, and to be clear, like this was the core of Josh's vision before I was brought in. Like I want to make sure that he gets, the credit for the scope of the vision of kind of what we would do, with me coming in and coloring in the details of it. But is really what we've ended up building, which is this kind of two-sided solution where we have this, this mobile app, right? This client-facing mobile app that allows our clients, our adolescent young adult clients, to engage with therapy in a way that is just using the technology they're used to. So the fact that their video platform would be on a mobile app, that would have skills and notifications and things, that would be their way of accessing mental health care. That was part of the vision early on, as was the idea that we would have therapists facing tools that would make it easy for therapists to deliver care, like not only their video platform, but tools that allowed them to deliver evidence-based care sort of in a way that was more interactive and engaging, and that those two products would intersect. So when we started, honestly, really what we had when we launched was the mobile app. That was sort of the heart of what we had, and an extremely basic therapist-facing platform that was pretty much just literally the video platform. So the mobile app had video, obviously, because that's what you need to be. You have to have video. You can't have a video therapy call. But the app had video features plus just, what Josh would say, sort of an MVP, like pretty minimal ability to push some information, mostly passive content to our clients. And the therapist facing side really had almost nothing except for the video. And then we were partnering with a third-party software for stuff like notes and scheduling and stuff like that. So that was it was a bit of a patchwork solution, with the primary go-to-market product being the mobile app. What we have spent most of, the latter part of 2020 and the first part of 2021 building is this therapist-facing platform, which is now actually a pretty robust product, continuing to sort of iterate on that mobile app. And what we're really spending the second half of 2021 on is making that mobile app experience just much more interactive and engaging for our clients. But we really started with basically an app and a therapist-facing video technology. That was all we had. And we used Google Space, we used Google Workspace, and a third-party software called Simple Practice, which is a clinical software, to kind of patch up the stuff that we couldn't provide to therapists yet.
So then going back to that moment, even almost like pre-launch, where you have two sides. You have your demand side, which is the teens, the young adults that are wanting therapy, and then you have these therapists on the other side that are going to be supplying it. Am I right in understanding that most of your therapists are contractors?
All of our therapists are contractors, except for the small handful of us that are clinical leadership who also take clients. Like I have clients on the platform, but most of our sort of like regular therapists are contractors. Yeah.
Got it. So actually then maybe let's go even further back. So you're like, let's go do this. How did you test the model of care? How did you know that, oh yeah, this is actually going to work over video, digitally augmented with these skills?
So I think there's two sort of levels to model of care. Like one is there's a science base, right? Like we're not recreating the wheel on what is evidence-based treatment for adolescent mental health. Like we know what evidence-based treatment is, so there's a bunch of stuff that we just pull from the literature that we know teletherapy works. Like that data was present before COVID. So there's a decent amount of data on teletherapy versus in-person therapy and the effectiveness of it. There's a lot of data on evidence-based treatments for adolescent mental health problems, right? And that data has been around for 20 years, right? So we know if I have an adolescent with depression, I don't need to go test how to treat them. I know from the literature how to treat them. I think the model of care is how do you leverage technology to sort of innovate on how you organize and deliver that care. So that's a slightly different nuance, if that makes sense. So like we didn't need to test that delivering CBT for adolescent depression through teletherapy would be effective. The data on that already existed. We didn't need to test it. Now, what's proprietary to us, what's more innovative is so some of the customized skills that accompany those live sessions, right? So how do you use a mobile app to practice a CBT skill? Now, there are lots of apps out there. There's lots of examples of how to do that, but we're also building our own proprietary content. Like, so the idea of, for example, how to teach someone to recognize the distortions in their thoughts. The fact that that's an aspect of cognitive therapy, no one owns that. Like that's just known in the literature. How we on the app teach that and have a client practice it, that's our proprietary technology of how we have them interact with that skill. Does that make sense?
That does make sense. So then maybe rewording that was really that when you launched minimally with the video aspect of like, we can actually do teletherapy. But did you launch with any of these skills?
We launched with minimal content. So we have two aspects of sort of proprietary content. Again, sort of therapist facing session planning materials, right? So if so if I'm a therapist and I'm going to be working with my adolescent with depression, and I know, or I'm going to have suggested to me by June, that some basics of cognitive therapy would be good here. So what are some basics of cognitive therapy? I'm going to teach the cognitive triangle. I'm going to teach cognitive distortions. There's 1,000,001 workbooks on how to do that. What we have done is sort of created step-by-step session plans for therapists about, hey, how could you teach that idea to an adolescent or young adult? Like, what's some of the scripted language that you might be able to use? How might you practice it in session with them? And then how might you assign it to them to practice in the skill on their app? So what we started with was minimal session content, honestly, session plans, like a handful, probably less than half a dozen. And then we had the skills on the app. We had a couple of custom built skills that we have done, 3, 4, 5, we were playing around with, plus a sort of space in the middle where we might be assigning passive content like, hey, watch a YouTube video, right? So what the therapist is directed to tell the client to do is to go watch a video with some instruction about how to practice it. So some of the content right now is more passive and pulls in other materials that aren't proprietary to Joon while we continue to iterate and do this. But we started with less than a dozen, both session content that was therapist facing and skills that were client facing.
Got it.
And we've just been building as we go.
Yep. And when you launched, were you the only one taking on patients at launch? Or
I actually didn't take patients right away. Although my academic credentials were really helpful here. So one of the things that happened when COVID hit was all graduate students, all trainees in both master's and PhD level programs who had been in clinical sites, when everybody shut down, they sent all their trainees home. Like, you may have seen this, like medical residents weren't allowed to see patients, right? Like, and so same thing with psychology trainees or LMHC trainees. As clinics now, they came back, but for the first 3 months of COVID, for the most part, trainees could not go do in-person therapy or training. So we had a whole world of graduate student trainees who couldn't see clients. Now, that kind of training is really important for their professional development. They can't go and apply to internships or their additional licensure unless they're getting those hours. So it's almost like all their training paused. So that was the space we stepped into. And so actually our first therapists were master's level clinicians who were working on PhD programs, who were very eager to find a way to continue seeing clients and getting training hours. And so we brought them onto the Joon platform first, while we started then hiring and bringing on other licensed professionals.
So you had actually tapped these therapists in training before
we
launch.
Tapped our own, I tapped sort of my personal network of people who were just eager to get some hours in the teletherapy platform because, for example, University of Washington or Seattle Children's or any one of a number of clinics, it just took them a while to figure out how to do teletherapy, right? Like when they couldn't have patients come in person, everyone figured it out eventually, but there was a space in there where no one had anything figured out. So we took our first client, I think the first week of April, first or second week of April of 2020. So if you think about when COVID hit, that was pretty fast, right? So it probably took until summer for a lot of clinics to figure out how to enable the technology, how to, get resources in a HIPAA compliant way to their therapists and to their patients, ensure that patients had technology. Whereas because we already had a mobile app and other things we were using just needed web internet for the therapist perspective, we could actually connect those dots pretty quickly.
So you definitely had a first mover advantage on the supply side to actually get therapists in the door really quickly.
For sure.
That's awesome. How was it on the demand side? How did you get that first patient?
Some of it came from sort of personal networks of mine, right? I've been in the Seattle area for a long time. And so not necessarily referrals to me personally, but it was pretty easy for me on behalf of Joon. And this would be true for most clinicians working in settings like this, is we have networks, right? So I reached out to every therapist I know, all of my former students who are now licensed and seeing patients, pediatricians I'd worked with and partnered with. A lot of these folks were also kind of frozen. They didn't know about, and teletherapy is a very different thing if you've never done it before, to just say, hey, I have a way to get adolescent and young adult patients seen through this teletherapy, platform that I'm working on. So if you got referrals, feel free to send them our way. We can serve them. And this is a really common clinical thing, is that, most clinicians want to see patients in need getting helped. And so we're often referring to each other. Like, we're not proprietary about our referrals. Or sort of like, the referral comes into me and I can't see them. I'm like, hey, why don't you go try so-and-so? Why don't you go try so-and-so? Because I'm trying to help connect you with services. And so I just kind of put the word out, right, to my network. And then that sort of spreads. We went on the, like, Seattle Children's has is in partnership with the state of Washington for a family mental health referral line. We went and put ourselves on the mental health referral line. So things like that, and just kind of got the word out that way, while we started building the infrastructure to do sort of more direct to consumer marketing, search engine, marketing and things like that from a business side.
Network definitely makes sense as like the easiest and quickest thing to tap first. I'm curious, like, at least when we think about even like the traditional startup-y tech thing, when you're looking for early customers, you really want your early adopters, because frankly, the product at the earliest stage is going to be kind of funky. It's going to have some funny things going on.
Yeah.
So you need someone who
you
has
need a lot of flexibility, both in
Yes.
those early customers and in those early therapists, right? They kind of need to be willing. There's a lot of change. I mean, I think our therapists have had to go through a lot of change as we've transition them off of other software platforms to our own proprietary platform. And so we were pretty mindful those first probably 10 or 15 hires to not just hire for sort of, content expertise and familiarity with the population, but kind of like flexibility and being able to, like, flexible mindset. Like, who do we think when we say, like, in technological savvy, right? So, there's a lot of therapists out there who've been just doing things their way for a long time. And you're like, now I need you to use these two different software platforms. You've never seen them before. Like, not everybody can just adopt new software. So we learned that there's like a little funny extra skill set you need with therapists, especially those early ones, to be able to kind of flexibly grow with you.
Do you think COVID helped with that? Like, everybody kind of had to say, I guess I got to be flexible now, because, like, what else can I do?
Yeah, I do. I mean, so there had been some therapists who were doing teletherapy before. So that was helpful. Some, by the time, we were 3 or 4 months in, some were, of course, had no choice but to have learned it in their other settings too. Like, most clinics had to figure this out pretty easily. I think the biggest thing that COVID was helpful for, and I do always really like to point out, like, we were teletherapy by design pre-COVID. Like, we were not a COVID reaction company at all. It just happened that the timing lined up. And there were a lot of reasons, like, why we were committed to a teletherapy model. And we get asked all the time, like, are you going to move to an in-person model? And we're like, no, that was never in our plans. We intend to be a remote teletherapy solution permanently, for a whole bunch of clinical and business reasons. But I think the biggest thing that COVID has done is just really increased acceptance of teletherapy as a delivery mechanism for mental health care. I think that was a place where I think physical health care had started getting broken down before, but I think both sort of traditional healthcare and mental health care, I just think you've seen there are a lot of people who are like, you can't, how could they diagnose? How could they do this? How could I have a relationship with someone? None of this can happen by video. It has to be in person. I think we've just broken down that idea. And the other advantages, which we knew about teletherapy, or any telehealth delivery mechanism, all those advantages have just become much clearer. So that's been the biggest advantage of COVID to us, I think, is just less education upfront that we had to do about why teletherapy.
And how did you dance the line with your earliest patients in terms of setting expectations on the product front, or measuring that flexibility of, like, things may go awry, but we're still here for you?
Yeah, I mean, so I think there's two things. So one is, if you think about our overall model of care, where we're sort of balancing kind of, live therapy and that sort of the strength and power of the therapeutic relationship, the one-on-one relationship with a therapist, with digital solutions that sort of support and amplify the work of that therapy. All we really have done is kind of shifted on a continuum over time, right? So early on, more of the work and delivery of care relied on that one-on-one interaction between the therapist, because the digital solution didn't have as many resources to support it. But we've just added resources. So it's just sort of really like, if you think about clinical scope, all we've really done is like, this is really all you can operate, but now you can operate all the way up through here. So it's more about a magnitude than sort of a shifting of the ability to deliver care. But I think the other one is that operationally, we've just really been committed to a great client experience early on. So that, we've been flexible in finding solutions when there are technological, you know, problems. So I think that's probably what has built, and we have for, we're more than a year in now, so the capacity to see how many of what our retention looks like, over a longer period of time, even more than the short-term anticipated sort of traditional course of therapy. And actually our retention rates get higher over time. Like the longer someone's with us, the more likely they are to continue working with us. So I think that says something about even those early adopters having had a good relationship, in part because the first part of it, the sort of foundational piece, which was making sure they had a really good therapist who knew how to treat what their problem was, that's always going to be a core of our therapy, and that's less technologically dependent. Everything else makes it easier, amplifies it, strengthens the ability to deliver care.
I'm really curious about how technology may or may not have helped the linking of parents into this whole process. Do you like? Could you speak a little bit more about that?
Sure. I would say the place product wise where we're still growing is solutions that integrate parents more seamlessly. So if you thought about what we said, we have a therapist facing platform and a child facing app. We don't actually have a digital solution that's just parent facing right now. One thing I'll say is that we treat 13 to 24. So we have a significant portion of our clients who are adults, right? There's not parents involved. But I think the way that technology has been useful in integrating parents is really in supporting therapists in doing that work. So the therapist-facing platform has session planning materials and blog posts and parent materials that are really easy then to facilitate their communications with parents and to send and to deliver to parents, so that parents feel included with some digital content and some like guides to having those parent therapist check-ins along the way from a therapist facing perspective. The other is that much of the communication, I think it's empowering the child client too. So on, the client facing app has things like I need to reschedule and reminders. So we actually can take the parent out of a lot of the sort of facilitating of the clinical relationship for the child, which is, empowers. One of the complaints we get from minor clients in traditional brick and mortar in-person therapy is how much their parents are kind of in their business, when teenagers just don't like that. They want this to be private and confidential. And when parents are scheduling the appointments and talking with the therapist directly, but when the client has their own app and their own way of communicating, actually part of how we integrate parents is by keeping them out of some of the logistics, because kids can handle that directly, if that makes sense. So it's a little bit of a both and, if that answers your question.
Yeah, it totally does. I think it's always fascinating, the more virtual we go, how parents can be linked into certain types of therapies, but also I actually love the angle of they're actually kind of kept out, which
there are
empowers
ways
the
in which
patient
we
themselves.
better engage our teenage clients because we can ensure their privacy and confidentiality, which they have a legal and ethical right to too, right? So there's a constant dance with adolescent mental health clients between their sort of rights to privacy and confidentiality and the clinical best practice of including parents in treatment, because it often can really supports the work of therapy when parents are on board, and parents' desires to be included, and they're typically the ones paying. So how to balance all those kind of slightly competing needs has definitely been something we've had to address. But one of our product goals would definitely be a parent-facing digital solution, whether that's an app or a website where they could see some of these summaries or just see, confirmation that their kid showed up for a session. They could reschedule and schedule things digitally. That is definitely in the longer-term product map.
You mentioned 13 to 24. Is 13 intentional? Is that to stay sort of away from COPPA or other regulations, or do you want to go younger?
Yeah, I mean, they're both developmental clinical reasons to kind of focus on the teenage and young adult years, along with kind of a best point for sort of age of consent and rights of confidentiality in most states, which does vary state to state. I mean, it varies anywhere from 12 up to 16, depending on the state. But I would say that the rationale for us is mostly because just clinically, most people consider children to be through age 12. So most both digital or health solutions, if they're sort of saying we are for children, will be 12 and under. Most that are for adult will say 18 plus. And there's very few solutions for that 13 to 17-year-old range. So we really wanted to make sure we were capturing that. And then clinically in both, I mean, health insurance also too will go up into the 20s, but clinically, 18 to 24-year-olds are more like 13 to 17-year-olds than they are like adults in a lot of ways. So there are both sort of clinical reasons and then kind of business model reasons, I think, to focus on that age range.
Can you speak more about you started out, you launched was it Washington State only?
Mm-hmm.
Okay. And your business model is largely cash pay or only cash pay?
Yeah. Yeah. It's all direct pay.
Got it. How are you guys thinking about engaging with payers to grow further? Like, what does that even look like in terms of getting started?
Yeah, it's a great question. It was really clear to us from the beginning that if part of our mission is to make healthcare more accessible, we have to bring the costs down. And that means allowing people to be able to access care without having to be direct pay. But it is, as I'm sure you know, and we made a very intentional decision early on. I mean, one, to accelerate our entry into market because of the COVID crisis, and two, to sort of test our model of care and collect effectiveness data so that we could then go to payers like insurance companies and EAPs. But we started those conversations. We're actually in the middle of conversations with several sort of insurers, EAPs, payers about ways in which we can be a sort of in-network option for them. There are a couple ways to do that. And you may have heard of it for mental health care. You can sort of do a fee for service model, or you can do kind of a bundled package model. And we are, definitely looking to work with insurers and payers as a sort of group, bundled model care, right? So that the payment model is not just the therapist hour, but all the other, support services, the technology that we're providing, the care coordination that we're providing, the offloading, the scheduling and billing, the technological support that we're providing. We don't want to get involved in trying to individually credential all of our clinicians on a fee for service model. That just isn't consistent with our business model. So we're having those conversations with insurers right now. I have one actually when I get off the phone with you. That's my next call.
Okay, that sounds very fun.
It is very fun, actually. And we're seeing very pleasantly that the adolescent mental health space is there are not enough solutions. There's so much need, so much crisis in adolescent mental health, and very few good digital solutions. So we've been really pleasantly surprised with insurers' interest in our treatment approach.
I was going to ask if you've either anecdotally or in your experience have seen insurers through COVID kind of become a little more amenable and perhaps quicker in terms of working with startups who are bringing novel solutions to the market.
I don't have a pre-COVID comparison. What I will say is that I do think COVID did two things to the mental health landscape that have put a lot of stress on insurers. So one is it's just increased the mental health need among adolescents and young adults while simultaneously decreasing services. So what happened with COVID was for two reasons. One, for safety reasons, right? Like a lot of inpatient IOP and PHP beds just got cut because, for example, you couldn't put two people in a room, right? So every single room now that was a 2-person room became a 1-person room. So this happened at every hospital, every IOP, every residential treatment program. Just for safety reasons, they had to reduce capacity. So everything went down at a minimum by half. But behavioral health, mental health, when all these, sort of HMOs, hospital systems started getting financial pressure, behavioral health tends to have the smallest margins. So if you're going to cut the smallest margin things and grow the bigger margin things, behavioral health programs are kind of the first to get cut at a lot of healthcare systems that were struggling. And so for those two reasons, like this increase in demand and then decrease in services, you've just had this tremendous gap in treating particularly adolescents and young adults. So we hear every week, I field stories from people who are like, my kid made a suicide attempt. We take him to the ER and the ER sends them home. And they're like, we don't have a bed. We don't have a treatment program. here's a list of therapists, none of whom have any openings. And this happens over and over and over again. And so insurers get stuck in this place where they're like, I mean, our choices are we can keep trying to find a residential bed and pay what, $10,000 a week, right, to take care of this kid, or find an outpatient solution if we can find anyone to take the kid. Well, if we can be the outpatient solution, there's a pretty significant market for that. So
yeah, it's a lot of market forces.
A lot of market forces
timing
simultaneously happening. Yeah.
Yeah. I want to be respectful of your time. So kind of my last question is, we want more clinicians jumping into the market, frankly, starting companies. What would you say to any clinicians who are kind of on the fence or thinking about it?
It's a great question. I think I would have two pieces of advice or things to think about. So one is, be willing to think creatively, right? Like if we have a big picture mission, if our big picture mission is to improve the lives of the people we went into these fields to serve, right? Whether that's medically or in terms of mental health care, most of us went in with a passion for serving people. So if you think about that and you think about, what are the options on the table that would allow me to have the most impact on the most people? Could I think outside the box on that? And is the opportunity here in sort of an innovative startup space to think outside that box and reach more people faster? Does that fit with my mission? And be willing to kind of think creatively about that. I think that's just a like psychological space that can be hard for people to kind of think outside the box that they're used to. So that would be the first one. And then the second one is the same thing, but said differently, which is, you know what your values are as a clinician, you know what you believe in and what's right. And, you can be willing to take risks and try something a new way if you're willing to stick to your values about what good care would look like or what is the right or wrong thing to do. They're not mutually exclusive. And if you trust yourself to make good clinical decisions at each point along the way, you really trust yourself to do that, then maybe that's what gives you the freedom to think creatively and try something new and take a risk. That'd probably be my advice. I don't know if that makes sense, but
yeah, we hope a lot of clinicians hear that. Well, Ian, do you have anything?
No, thank you so much for the time. This has been
really I hope it's helpful. Sorry I can't give more of the business perspective, but no. Hopefully the clinical perspective is helpful.
Really helpful.
It's super helpful. Amy, thank you for joining us, and good luck with the insurer call.
Okay, awesome.
I think probably this is like my businessy side. I like how they scoped it at launch. They said, let's start with the building block and the most known, proven thing, which is simply teletherapy.
Yeah. I like the thing that went through my mind for probably the first half of the conversation that I think is exactly kind of where you're headed as well was I kept thinking about the future is already here. It's just not evenly distributed, which I was like, wow, everybody knew teletherapy worked. Nobody did it. And she was like, we just did like evidence-based stuff forever. Like she harped on like, yeah, everything was evidence-based therapy. Like it and I'm
we're
like,
innovating, but we're not inventing.
Yeah. I was like, well, that just means that like everybody knew this stuff worked. Like,
right.
They just weren't doing it.
Right.
So I'm like, the future's already here. It's just not evenly distributed. Like you just like, you got to put the pieces together in the right way.
Right. Which chips away at that early adopter concern that every single startup has of like, are you going to be a good early user? It's like, well, can you do video therapy? Right. Yeah. Video technology is hyper known. And then a therapist who has done some kind of teletherapy or can be trained, that's a known that you can solve for. So there are very few like bugs at launch.
Right. And that was where my question about COVID came in, because it feels like, when you like there could have been hesitancy amongst patients for teletherapy, but they were forced that way, right? Like COVID forced them that way. So it was like, well, maybe they had hesitancy, but like they were still going to do it if they wanted any therapy, like it was going to happen.
Yeah. So. Yeah. I like that. I actually thought it was really, really cool that she's kept her academic position and that they play so nicely together. And I wonder if that's the case for most clinicians. Like, this is such a broad stroke, it's almost stupid to say, but like, is that the same for all clinically minded academics that if they did go private into a startup, that if they kept a foot in academia, number one, the university would allow that, and number two, it would actually be mutually beneficial.
Right. I thought that was pretty cool too.
Networks for early customers. We hear that. We know that. We hear it all day long. Mental health companies are no different.
Yep. Especially clinical stuff. Like if you can just, again, if you're just basically providing a new model of care, if you already have the patients to care for, moving them over is
exactly
great.
Yeah. And then it sounds like the referral path is free flowing and very mission driven.
Yep.
No ego about it. We didn't really get into the regulations. I guess we touched on it a little bit. It's very state by state. I'm sure direct pay helps.
Yeah, and yeah, you're right. We didn't touch upon it, but I do think, again, that was a place where COVID allowed them to extend pretty quickly because all of a sudden, your license was valid in all 50 states.
Oh, that's one. I don't know if that applies to all providers or certain types of providers.
Well,
because they are growing pretty purposefully state by state.
Yeah, that's a good question, but I do think it does.
We'll follow up with that.
Yeah.
Yeah, and then I hope someday someone schools us on what it's like to work with insurers like in detail.
Yes.
Like the real dark.
I think Molly did a good job of starting that. But man, just striking deals. Just it feels like such a black box. Like
honestly, even just getting in touch.
Yeah. Yeah.
Perhaps that's exactly. A Google away, but so we probably need a Google, but it does seem like, so who do you talk to? And then who says like, okay, so this is what the process is going to look like. Yep. And I did enjoy, Amy said, okay, you're going to take a little bit of time and then it's going to take a lot of bit of time, but overall they have such an opportunity ahead of them. Timing was like theme of this one, timing, man.
Yeah, and it was interesting that it was, I mean, more or less luck.
Yes. Yeah. It was luck. It was fortuitous that Josh and Amy were in the right place. Like Amy was in the right place career-wise to join. And then they were in the right place already planning virtual. And then COVID happened and accelerated everything. Luck in a very macabre way that demand skyrocketed while the ability to actually fill that demand plummeted.
Yep. So I'm just looking at the American Psychological Association, and many states had licensing waivers. Not every state. Many states had licensing waivers. Some of them were emergency. Some like you can just do it, no notice. Some of them were like, hey, no notice for X amount of time. Some of them were basically like, you got to contact us, give us notice that you're going to do it. So that is probably why they did not go all 50 states.
You got to contact like Department of Health Services state by state.
I think so.
Yeah. Well, cool. Anything else?
No. Yeah. She was cool. I really liked her.
Yeah. Good luck, Joon.
Yeah.